This is going to be a presentation discussing the both common and uncommon skin manifestations that you might see on the wards. This is a case of contact dermatitis. It's common in patients who present to the emergency room after exposure to common irritants, which can include cosmetics, metal latex, poison ivy, and antibiotics such as neomycin. The keys to diagnosis here are that you see that the patient's arm is edematous and also contains multiple bullae, which are weeping. Skin biopsy is normally not performed because it's often nonspecific. Treatment for contact dermatitis is often supportive. If failure with supportive treatment occurs, you can use topical corticosteroids and then also antihistamines. This next rash is a drug eruption rash. Most commonly, these present as maculopapular rashes. Common causes include allopurinol, beta-lactam antibiotics, sulfa drugs, anticonvulsants, ACE inhibitors, and NSAIDs. Tetracycline antibiotics have a predilection for giving a drug rash predominantly in the genital areas. NSAIDs are also commonly responsible for rashes and can give you a case of pseudoporphyria with bullous lesions that occur over the extremities. The keys to diagnosis in this case are that the rash and the lesions occur 1 to 4 weeks after starting the new drug. Skin biopsy is usually not specific and not done. Treatment is supportive care and discontinuation of the drug. This is a case of erythema multiforme. Clinically, it looks round, dusky. The lesions are red, and they evolve into target lesions over the course of 48 hours. They typically start on the hands and feet, as well as the extensor surfaces of the arms and leg. These lesions are usually symmetrical, and then can also involve the palms, soles, and oral mucous membranes. Keys to diagnosis are that the lesions are classically target-shaped. Skin biopsy is diagnostic, and care should be taken to do a biopsy from the non-blistered portion of the target. These lesions are self-limiting and frequently resolve on their own. This is a simple case of folliculitis. You can see that you have small pustules localized to hair follicles, and that is the key to diagnosis here. Skin biopsy is diagnostic, but is not usually done. The most common causes of folliculitis are infection from Staph aureus and Pseudomonas. Thus, you can treat these with topical antibiotics, and they should resolve pretty quickly. So this is a specific subtype of psoriasis known as guttate psoriasis. It presents as pinpoint to 1 centimeter large scaling papules on the trunk and extremities. The real key here to diagnosis is that the lesion is often preceded by a strep pharyngitis infection 1 to 2 weeks before the rash starts, and it also is one of the only rashes that presents as a scaling papule. These lesions can resolve on their own. However, you can also treat with phototherapy and tacrolimus as your first-line treatment, and if those fail, you can use topical corticosteroids. However, you should avoid the use of topical corticosteroids as they cause a rebound rash that is often more severe than the initial presenting rash. Here, looking at a case of lichen planus here. They present as flat-topped papules and plaques that commonly affect the ankles and the wrists. To diagnose, you can use your 5 Ps: pruritic, planar, polygonal, purple plaques. You can also see Wickham striae, which are reticular pattern of white lines on the surface of the lesions. These lesions also undergo a Koebner phenomenon, where you get the development of the lesions at sites of trauma. It's also common for other skin lesions, such as in psoriasis. Treatment here is topical corticosteroids or retinoids. Most of these lesions resolve spontaneously in 6 to 9 months, even without treatment. This is a case of pityriasis. You can see that you have round to oval pink lesions that range from 5 to 10 millimeters. They often distribute in a Christmas tree pattern on the back. 20 to 50% of the time, they're preceded by a solitary 2 to 10 centimeter oval pink scaly herald patch. Key to diagnosis is that they have this oval shape and are oriented with your skin lines. It looks similar to secondary syphilis, and you should rule that out. No treatment is required here, but you can use oral antihistamines and topical steroids if the patient complains of itching. HHV 6 and 7 have been hypothesized to be the cause of this, and acyclovir has been shown to reduce both the length of duration and severity of the rash. This is a case of scabies. You can see you have vesicles, papules, and erosions. Commonly, they affect the finger, wrist, elbows, groin, belt line, ankles, feet. The key to diagnose this is that they're commonly in this characteristic distribution, and the patient complains of really severe itching. They'll also have a positive mineral oil mount. Treatment includes permethrin, but you should make sure to treat the entire household and any other individual who's had prolonged contact with the patient. Make sure that when you treat the entire skin surface and not just areas where the lesion is located. This is a case of seborrheic dermatitis. You can see you have an erythematous patch, and they commonly look greasy. The lesion's commonly located behind the ears and on the scalp, but can also be in the external ear canal, base of the eyelash, eyebrows, central chest, and under the armpits. The key to diagnosis is that it has that classic greasy scale appearance. When working up this patient, you should work up the patient for HIV infection, and then this is also a common autonomic symptom seen in those with Parkinson's. Antifungals and topical corticosteroids can be used to treat this. So this is a patient who will come in complaining of intense itching on the elbows. They may also complain of GI issues. So this is a case of dermatitis herpetiformis. These lesions are pruritic, symmetrical, present as papules and vesicles, and are often located on the extensor surfaces, including the knees and the elbows. Most patients also have a history of celiac disease. Treatment for this includes changing to a gluten-free diet to treat the celiac disease, but also dapsone is an effective treatment. This is a classic target lesion associated with Lyme disease, also known as erythema migrans. You get the lesion at the site of the tick bite, and it progresses to a generalized macular lesion on the proximal extremities and chest. The key to diagnosis is that the patient will report a history of outdoor activities, and the incidence of Lyme disease is most common in the northeastern United States. Treatment includes doxycycline. However, doxycycline is contraindicated in children younger than 8 and pregnant women. And in those instances, you can use amoxicillin or azithromycin to treat. This is also a tick bite associated lesion. It's Rocky Mountain spotted fever. It presents as a 2 to 6 millimeter macule that spreads centrally from the wrists and ankles and progresses to papules and petechiae. It can often involve the palms and the soles, and the patient will complain of a prodrome of fever, headache, photophobia, abdominal pain, and nausea and vomiting. The key to diagnosis here is that the patient will report outdoor activities in an endemic area, commonly the southern Atlantic states. You need to begin treatment immediately if you suspect Rocky Mountain spotted fever, even before laboratory confirmation. Failure to respond to tetracyclines actually argues against the diagnosis. Doxycycline is the first-line treatment. However, you can also use chloramphenicol. Keep in mind that if you're using chloramphenicol, you have to do lab monitoring because you can get an aplastic anemia in patients. This is a case of a patient with secondary syphilis. The morphology is variable, but it usually presents as a red-brown scaly papule that involves the palms and the soles. Oral and genital mucosa are also commonly involved. Key to diagnosis here is to get a positive syphilis serology test. Skin biopsy is nonspecific and is not often done. First-line treatment for secondary syphilis is still an intramuscular injection of penicillin G. For those who are allergic to penicillin, you can use doxycycline. This is a case of pyoderma gangrenosum that presents as necrotic ulcerations. There are multiple subtypes of pyoderma gangrenosum. However, the classical form commonly affects the legs. The ulcers initially look like small bug bites or papules and then progress to large wounds. Commonly, a patient will have a history of ulcerative colitis. However, pyoderma can occur with a lot of other autoimmune conditions. The key to diagnosis here is that pyoderma demonstrates pathergy, where the wound gets worse at sites of trauma. First-line therapy is systemic treatment with corticosteroids or cyclosporin. You want to avoid surgical debridement of the wound because it demonstrates pathergy, and the wound will just get worse if you try to debride it. This is a case of mixed cryoglobulinemia. The key clinical features here are that in about 90% of the time, this presents as erythematous macules and purpuric papules. The patient also complains of Meltzer's triad, which is the purpura, arthralgias, and weakness. The lesions here have a predilection for dependent areas and are commonly seen in the lower extremities, as in this case, the foot. Treatment of asymptomatic cryoglobulinemia is just supportive care. Types 2 and 3 are associated with hepatitis C, so a patient should be worked up for hepatitis infection, and then treatment of the hepatitis will also resolve the rash. This is a case of Sweet syndrome. The lesions here start as red tender papules and then evolve into painful erythematous plaques and annular lesions, commonly on the upper extremities, head, neck, and back. The key to diagnosis here is that this commonly occurs in middle-aged and older women, and you're going to need a skin biopsy to completely diagnose. The gold standard treatment here is systemic corticosteroids. That proves a rapid improvement of the rash. This is a simple case of urticaria or hives. The lesions are discrete and confluent. They're raised, edematous. They can be round or oval. They vary in size, but they can have an erythematous border with a pale center, which is classically described as the wheal and flare. The patient will complain of a history with a drug and food allergy or some exposure to an irritant. Treatment here is just supportive. This is a patient with toxic epidermal necrosis. So these lesions fall onto a spectrum, with erythema multiforme being all the way to the left and then toxic epidermal necrosis being all the way to the right. The difference between Stevens-Johnson's and toxic epidermal necrosis is the amount of total body surface area that's involved. Less than 10% is involved with SJS, and then greater than 30% is involved with TEN. The lesions here commonly affect the oral mucosa, genitalia, palms, soles, and they're painful lesions. Skin biopsy is diagnostic and is routinely done. The treatment here is controversial. The lesions are treated as burns, and so the patient should be in the burn ICU. The use of steroids hasn't been shown to be effective in reducing the duration or severity of the lesions. This is the palpable purpura seen with meningiococcemia. The lesions start as erythematous papules or pink macules and then become non-blanching petechiae. The lesions usually spare the palms and soles. The patient will have a positive blood culture. A skin biopsy is usually nonspecific and not done. These patients should be treated for sepsis. This is a patient with subacute cutaneous lupus erythematosus. The lesions here can either be papulosquamous or annular, as is the case in this picture. The lesions are mainly on the trunk and in sun-exposed areas and can also be drug-induced. The patient will be ANA positive. Skin biopsy is diagnostic and is routinely done. Treatment here should be topical steroids and then also advising the patient to avoid excessive sun exposure. This is a man who has genital herpes. The lesions here are classically described as grouped, painful vesicles. The lesions typically last between 7 to 10 days, and treatment can be started with acyclovir. This is the case of the chickenpox. The lesions here are classically described as vesicles on an erythematous papule, and on test questions, it has a dewdrop on a rose petal appearance. The key here is that the patient will have all stages of the lesions, including papules, vesicles, pustules, and crusts, at the same time and in close proximity. The diagnosis here is usually clinical, but can also be done using PCR of a skin lesion. Skin biopsies are diagnostic, but cannot distinguish between a herpes zoster infection or a herpes simplex infection. This is a patient with measles, also known as rubeola. The rash is classically maculopapular and purple-red that become confluent as the disease progresses. It typically starts on the face and behind the ears. You can also see Koplik spots, which are tiny red or white spots with a red halo on the buccal mucosa. This patient has rubella. The lesions are round, pink macules and papules that start on the forehead, neck, and face, and then spread to the trunk and extremities, including the palms and the soles. This lesion is known as ecthyma gangrenosum. Primary cutaneous lesions of ecthyma gangrenosum initially appear as painless, round, erythematous macules that become pustular with surrounding erythema. These then have a hemorrhagic focus in the center. Patients can typically have either a single lesion or multiple lesions, and they can appear anywhere on the body. However, it predominantly affects the anogenital and axillary areas. Commonly, these lesions are seen in immunocompromised patients. The classic test question is a patient who has ecthyma gangrenosum secondary to Pseudomonas and has a history of uncontrolled type 2 diabetes. This is a case of erythema marginatum. It's described as pink rings which can occur on the trunk and inner surfaces of the limbs. They can come and go for as long as several months and classically appear on extensor surfaces. The rings are barely raised and are non-itchy, and the face is generally spared. In 5% of patients with rheumatic fever, you can see these lesions. They are also considered a major criteria in the Jones criteria. There has also been an association with bradykinin, and you may see these lesions in patients with hereditary angioedema. This is a patient with Fifth disease, also known as erythema infectiosum. In children, you'll have a slap cheek appearance with sparing of the periorbital areas in the nasal bridge. The rash classically has a fishnet pattern. In adults, they won't have the rash, but they'll complain of arthralgias, and then they'll also have a history of exposure to a child with the infection. The rash is secondary to an infection with parvovirus B19. Skin biopsy is nonspecific and is not usually done, and the treatment here is just supportive care. This is an example of erythema nodosum, which is an inflammatory condition characterized by inflammation of the fat cells under the skin. What you see are tender red nodules or lumps that are usually on the shins. It can be caused by a variety of conditions, but resolves spontaneously between 3 to 6 weeks. It's common in young people between the ages of 12 and 20 years old. This next condition is known as erythrasma. It's a skin disease that causes brown, scaly skin patches. It's caused by the bacterium known as Corynebacterium. It's prevalent among diabetics and the obese. The patches are initially pink but progress to become brown and scaly as the skin starts to shred, and they're sharply demarcated. They're typically found in skin fold areas, under the armpits, under the breast, and the groin, and then the lesions can also affect the webbed spaces between the toes, which makes it hard to distinguish it from a fungal infection. However, you can use Wood's lamp to cause the lesions to fluoresce, and this will help you distinguish it from other bacterial infections. However, keep in mind that fungal infections will also fluoresce underneath Wood's lamp. The treatment here is systemic macrolides such as erythromycin or azithromycin. Here we have an example of cutaneous aspergillosis, which is usually a manifestation of disseminated infection with aspergillosis. The dermatological manifestations are either a single or multiple erythematous to violaceous plaque or papules, which often have a central necrotic ulcer. Skin lesions only occur in 5 to 10% of patients who have disseminated aspergillosis.